Hello everyone, I am Dr. Prashant, and in this presentation we will talk about hemoptysis. Hemoptysis is defined as expectoration of blood from the respiratory tract. The source of the bleed, in addition to from the respiratory tract, may be from the nose, in which case it is epistaxis, or from the gastrointestinal tract, in which case it is hematemesis. Let us analyze the anatomy and physiology of hemoptysis. There is a dual circulation scheme in the lungs, in which there is a pulmonary circulation, which is a low pressure system for gas exchange, and a bronchial circulation from where most of the hemoptysis arises. This is under systemic arterial pressure. The etiology of hemoptysis may be classified into infections, vascular, malignancy, and mechanical and other causes. Infections may include viral, bacterial such as Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis, tuberculosis, which can cause bronchiectasis and Rasmussen's aneurysm. Fungal infections may also cause hemoptysis, specifically aspergillosis and nocardia, and paragonimiasis may be a helminthic cause for hemoptysis. The vascular causes of hemoptysis include pulmonary edema, pulmonary renal syndromes such as granulomatosis with polyangiitis and anti-GBM disease. There may be an arteriovenous fistula causing hemoptysis and diffuse alveolar hemorrhage due to systemic lupus erythematosus, cocaine toxicity, and hematopoietic stem cell transplant. Malignancy may also cause hemoptysis. Small cell and squamous cell carcinoma of the lung may be an etiology. Metastasis to the lung from the breast and the colon may also cause hemoptysis. And finally, Kaposi's sarcoma may also be a cause. Mechanical and other causes include foreign body aspiration, pulmonary endometriosis, which can cause catamenial hemoptysis, which is hemoptysis during menstrual periods, pulmonary arterial catheters, and coagulopathy and anticoagulants. The evaluation of hemoptysis includes taking a detailed history, conducting a thorough physical examination, and diagnostic studies. In history, the amount of hemoptysis is of critical importance. Additionally, fever, chills, and cough might suggest infection, and we must take a detailed history for risk factors for malignancy and cystic fibrosis. In general, 400 ml of blood in 24 hours is thought to be massive hemoptysis. Physical examination may reveal tachycardia, tachypnea, and hypoxemia, which may suggest infection, hemodynamic instability. However, exsanguination due to hemoptysis is rare. Clubbing may suggest bronchogenic carcinoma, and signs of bleeding diathesis, such as ecchymosis, may be a clue. Diagnostic studies include a complete blood count, coagulation parameters, and renal function. A CT and a CT angiography may be required, and flexible bronchoscopy must also be considered. The management of hemoptysis includes 3 simultaneous goals. These include protecting the non-bleeding lung, locating the site of bleeding, and controlling the bleeding. We'll learn about the interventions to control hemoptysis with the schematic diagram. This is the bleeding lung and this is the non-bleeding lung. We must keep the non-bleeding lung up and the bleeding lung down to protect the other lung. Endotracheal intubation is inferior to cough in removing the blood. However, if it is indicated, it must be directed towards the non-bleeding lung. In that, we must carry out selective intubation. Finally, controlling the bleeding may require one of these 3 interventions. Intervention from the airway, from the blood vessel, or surgical resection of the vessel as well as the airway. Bronchial artery embolization is another procedure which may be carried out to control massive hemoptysis and is generally successful in the short term. Treatment of the underlying disease is required to prevent recurrence. However, a dreaded complication of bronchial artery embolization is spinal artery occlusion. We will now discuss an approach to a patient with hemoptysis. After a history and physical examination, and after ruling out bleed from the oropharynx and GI tract, we can classify the hemoptysis into non-massive and massive. If the hemoptysis is non-massive and the patient has no risk factors, we must treat the underlying disease. However, if there is persistent bleeding or the patient has risk factors, then we must do a chest x-ray, a complete blood count, urinalysis, creatinine, and coagulation studies. We can consider a computed tomography, bronchoscopy, and we must make an attempt to treat underlying cause as usual. If the bleeding persists, then bronchial artery embolization or resection must be considered. If the patient has massive hemoptysis, we must protect the airway, and if the bleeding stops spontaneously, then no further intervention is required. However, if the bleeding continues, then we must consider embolization or resection. That's it for our presentation on hemoptysis. Thanks for watching, and we will see you in the next video.